Okay, so the government is reopened after weeks of the failed Democrat policies and shutdown that left a lot of people out of work, out of pay. President Trump has just signed the reopening of the government, but there's still a problem to be solved. And that problem was actually expressed last week in Barbara Boyd's uh, presentation that she gave her update on the real shutdown story. And that presentation received a lot of attention, including attention from the President of the United States himself. Now, the real shutdown story, she emphasized what Trump exposed of the big lie of the Democrats, which I want to reiterate here again, and as President Trump made a real proposal on what has to be done about the problem that still faces us on the question of the healthcare crisis that our country is facing, and the idea that the Obamacare policies, Affordable Care Act, have been nothing but a big lie, a joke, and they do not work. But let's go back again to what was presented in that video, recapping again. Second, please. Uh, and I will restate again what Fox News, Barbara Boyd, and others restated from President Trump's Truth Social just about a week ago on November 8th, 2025. As it reads here, I am recommending Senate Republicans that the hundreds of billions of dollars currently being sent to money sucking insurance companies in order to save the bad health care provided by Obamacare be sent directly to the people so they can purchase their own much better health care and have money left over. In other words, take from the big bad insurance companies, give it to the people, and terminate per dollar spent the worst healthcare anywhere in the world, Obamacare. Unrelated, we must still terminate the filibuster. So that's what Trump proposed prior to the reopening of government, and proposed in dealing with the healthcare crisis that now has to be addressed within the next two 2 months or prior to January. So tonight we're going to be joined by Brian Lance to expound on that. What needs to be addressed concerning how do we address the healthcare crisis? What are the actual problems that we're facing? And what are some of the solutions being presented? And what do we say here at Promethean in Action about what needs to be done to address this problem? So, with that, I want to turn it over to Brian Lance for his opening comments and discussion.
Okay, thanks, Keisha. All right. Well, I think most people know healthcare costs are just out of sight, and particularly as Charlie Kirk, among many others, emphasized, it's got to be solved for young families. Healthcare, housing, these are critical issues. We've been addressing them here. And so tonight we're coming back to healthcare and what actually needs to be done. Uh, just if you go to the slide, the graph there, Keisha, just to give an idea, you know, we have this weird system in the United States. The actual cost, total cost of healthcare, 70% is covered by taxpayers. It's paid by the government, 70%. Yet the private sector, quote unquote, private sector, insurance companies, Wall Street, publicly traded insurance companies run the healthcare system. So the government is the taxpayer, therefore, is paying for healthcare, 70% of it. Here you see it in this graph. The red is what people are paying for their premiums and so forth for healthcare. The blue takes into account the subsidies that are also being paid simultaneously directly by the federal government to insurance companies to continue Obamacare, the ACA, Affordable Care Act, et cetera, and to the Advantage Plan, for example, that's been taking over Medicare, which is privately operated. It's being subsidized. And it's been pointed out many times that, the idea of the subsidies was to help get the insurance companies squared away so that programs can pay for themselves. But every time the subsidies get paid, then the costs actually go up. The costs don't go down, the costs go up. And that's what we've been stuck with. Um, um, just unaffordability and high co-pays and and all the rest. And we'll talk a little bit more about that. But I don't want to just uh, dwell on the problem. The next slide. Uh, Interestingly, in 2023, Senator Tim Scott, Republican of South Carolina, introduced a bill in the U.S. Senate to uh, uh, allocate money directly, to allocate money back to people so that they could pay for direct primary care. That's what it's called, direct primary care. In other words, through health savings accounts, money would go back to citizens, and from those health savings accounts, they could just pay the doctor directly for health care using that money. Um, that bill's now been reintroduced. That bill in 2023 already had 3 or 4 co-sponsors, including Mark Kelly of Arizona, Democrat, um, Janine Shaheen, Congresswoman from New Hampshire. As Democrats, they signed on fulsomely to Tim Scott's proposal. That was 2023. That bill's now been reintroduced by what was then the other co-sponsor, um, Senator Cassidy of Louisiana. He now reintroduced it, and here you see it, the Primary Care Enhancement Act of 2025, Senate S 1719. That's Senate Bill 1719. And you can go to congress.gov and you can get the rundown on it. And you see that Senator James Lankford of Oklahoma is also signed on as a co-sponsor to the bill. There may be additional co-sponsors now. Now, the proposal, this is along the lines of what President Trump is calling for. I'm not saying this is what President Trump wants. This is applying to health savings accounts, which have a defined range or accessibility. People have to already have insurance, low cost insurance, bronze or catastrophic healthcare programs, and some others qualify, where they have very, very high deductibles. They're paying the lowest possible in terms of premiums, but they have very high deductibles, and those folks qualify to set up health savings accounts. And these health savings accounts, this legislation says, well, we should give cash back to these people, locked in, can't be used, as President Trump says, can't be used to buy a Cadillac. This money should go back. We should send cash back to these people in the sense that it's in these health savings accounts, and they can use it to negotiate with their primary physician, the physician they trust, and pay a monthly fee that would cover all their health care costs, or virtually all health care, not hospital care and whatnot, but basic primary care for them, potentially their family. There's an upper limit in terms of what would be spent. But this legislation just indicates that what President Trump is proposing in broader terms for all Americans is on the table. It's on the table in 2023. and it's been under discussion since, and it's been introduced again as of May of this year, and President Trump wants to expand that out. So this is very useful, and it's particularly important, I think, if you have in mind that literally 40 to 50% of all healthcare costs in the United States, the healthcare system, the costs are in overhead between 40 and 50%. Studies vary from what, you can get a range, but that's the range. 40 to 50% of all healthcare costs are in overhead. It's not in healthcare delivery. It's insane. This is why the U.S. has the most expensive healthcare in the world, and it's no longer the best either. That went away some time ago. So obviously, this oligarchies create create bureaucracies, and we've got this massive bureaucracy in healthcare through via these publicly traded Wall Street insurance firms, United Healthcare, et cetera, and then through these networks of hospitals, and of course down to doctors' practices, which are increasingly bought up, particularly specialized medical practices, are bought up by equity funds and doctors basically become hired sharecroppers working for the equity funds because they just give up on handling all the paperwork, all the overhead. Additionally, what we've had a big problem. Well, well, to mention one, if you move on 2 slides the next chart briefly here, Keisha. This is the last chart. I'm not going to bore you with a lot of charts. But look, Medicare and Medicaid, this is another major problem that we have. Medicaid and Medicare do not cover the actual costs. Move on to the next slide. Yeah, there we go. Do not cover the actual costs of providing medical care. Medicare and Medicaid provide a fraction, a significant fraction, but way below what's required. Here is a chart comparing the Medicare fee schedule. That's in red. That's essentially what the medical what the physician is getting in red, and then what are the actual costs? The Medicare Economic Index, that's the upper one in gray. The it's taking into account inflation, but it's more than that. So you see here that what physicians are getting, this is in broad brushstrokes, but this is the accepted parlance of the in the medical field. These figures, the doctors, and that means the nurses and the practices as a whole, and so forth, are getting say 70%, 80% of their actual costs covered, and the rest, well, the rest has to be made up somehow. It's the same with hospitals. Hospitals treating Medicare, Medicaid patients are getting reimbursed through CMS, that's Medicaid and Medicare. They're getting repaid on the order of 70, 75%. So how do they compensate for that? They have to compensate that or they quickly go out of business. Well, that's where they shift. They shift the expenditures. The cost shifting, as it's called, is that it goes to not just to the poor soul that walks into an emergency room out of their program and just has to get service from the whatever physician is available, and then gets a bill 2 weeks, 4 weeks later for umpteen thousands of dollars. It's also that, and this was known at the time that Obamacare was enacted. This Obama knew this. The Democrats knew this. that the expansion of Medicaid under Obamacare. This is in addition to the platform, the Affordable Care Act platform of healthcare. But the expansion of Medicaid added 21 million people as of 2024 to the Medicaid rules because it expanded the types of people, including adults and so forth, that could qualify for Medicaid. But it didn't expand the number of doctors and nurses. Um, so, so the costs of this, of these folks coming into the system, was borne by increasing the copays and the annual percentage of the programs, of the Medicare programs, of employees employed by companies. In other words, blue collar families, working families, or the spouse who's the breadwinner of the family, um, are saw their deductible or their portion of the program skyrocket. The amount that the average worker pays for his health insurance program himself today is around $1,750. For a family, it goes rapidly up to $4,000 or $5,000. That's what he's paying to have a health care program through his company that's paying on average around $25,000 a year to insure him and his family, if he has a family as well as that is insured. So these costs are the costs of Obamacare, because the underlying reason, if we step back, the underlying problem and the underlying solution is to grow the economy, to grow the U.S. economy. We've got to strip away the bureaucracy. And one way of doing that is getting funds going directly through the states or otherwise directly to an expanded health health savings account system. But at the same time, what we have to do is expand the productive capacities of the economy as a whole, the United States economy as a whole. Right now, we have 10% of our workforce that's in manufacturing, 10% at max. We have less than 25% of our workforce in all forms of industrial activity. From moving from heavy transport to energy to construction to agriculture to manufacturing, all told, putting it all together, including manufacturing, 25%. So, in effect, 3/4 of our workforce is an overhead. Some of it's very important. It's not unessential, but it's overhead relative to what's actually making the physical changes on nature, producing the actual physical wealth, which is what free energy comes down to. What do you have to deploy to fund programs? Who pays for the food that the doctor and his family eat? Who pays to build the house that the doctor lives in? How is the hospital built? Where does the concrete come from? The steel? Where's the electricity come from? And so on and so forth. It's a bill of materials. You can break it down in terms of the economy. And if we increase, as the Trump administration, as everyone here knows, is committed to expanding the percentage of the population that's productively employed in high wage, skilled, highly productive jobs. If we're expanding the proportion of the population that's productively employed, they're earning more, they're more productive, then you're generating as a society the free energy above your costs, immediate costs of simply reproducing yourself. You're producing a free energy capability above that, above just maintaining your society. And that free energy can then go to improving the conditions of life. This is extremely important. Back in the 1970s, '71, the dollar went off the gold standard, was taken off the gold standard. Uh, and when we went to a service economy. It had already started. At that point, we said, "Hey, we're all in." And that was the policy of the Federal Reserve. That was the policy. That was the currency of the realm. We were going into a post-industrial society. As a result of that drift, we were setting inflationary pressures into motion. And with rising inflation, it was decided, well, we got to cut the costs. Well, medical care is costing too much. It was said that we cost too much for all these new medical devices and so on and so forth. Actually, medical care at that time was going up at a slower rate than the rate of inflation, which by 73, 74 was 11 or 12%. But, healthcare was around 6 or 7%. But anyway, this was the storyline, the narrative. And so this is where HMOs and insurance companies came in. We starting with health maintenance organizations, which were organizations that provided insurance and simultaneously provided health care, like Kaiser Permanente, which was an early model. They were tied from the start to the insurance industry. In other words, you were saying, okay, well, healthcare is getting too expensive, so we're going to introduce the profit motive, and the profit motive will help us cut corners, cut costs, and find ways of saving money, because there'll be the motivation to save money so profits can be made. Well, the consequence of that now, 50 plus years later, is a bureaucracy that's bean counting and bean counting the bean counting and holding seance sessions over how to get fewer to save fewer beans or whatever. And everything is costing much, much, much more. Where if we had, as an economy, as a United States, as a producer country, as a producing nation, continued to commit, or committed to reindustrializing, as we were saying at the time, as the economist Lyndon LaRouche was calling for at the time, emphasizing that this could be and must be done. That the taking the dollar off the gold standard was just a sign of the times. It was the canary that was dying in the mine shaft. It was proof that we were no longer able to pay our own bills, that we were no longer producing at the required levels. If we had done that, if we had shifted and said, hold on a second, we can correct this. We've corrected this before. We'll correct it again. We could have launched a rebuilding process. We could have generated the free energy. We could have brought the costs of things down. We could have made everything more affordable. And the world would be entirely different today. It would look entirely different today, including in healthcare. And that is indeed what President Trump and his team of principals, his group of 24, 25 cabinet level people, and his collaborators in the private sector and state government and so forth, are intent on doing. I think most of this is not understood by most elected congressmen. Rhinos, trinos, Democrats, they don't understand this. Trump is doing an about face, or put it another way, he's turning the world right side up. We're going to rebuild the U.S. economy. This is what we're in the process of doing. That's the ultimate solution overall to the healthcare problem. But in the context of that, we can take the steps along the lines of what President Trump has now opened up, the real debate, what the Democrats were trying to avoid. They were saying, oh, well, we've got to protect people on Medicaid. Trump's going to throw all these people off Medicaid. That wasn't the case. It wasn't what was behind the Democratic Party in terms of the actual people in the know, the Schumers, et cetera, et cetera. they were intent on saving the Wall Street insurance companies. They were out to pump up Wall Street insurance companies with additional trillions of dollars. That's what they were trying to hold Trump and the country, our nation, hostage for. Trump has called them on that and said, no, we're not, we're breaking with this, where we're going to take the billions going to these money sucking insurance companies. That was his terminology. And we're going to get it back to people where they can, with their doctors, with their physicians, work out health care on a reasonable basis. And basically sideline the entire overhead. So I think that's the crux of it. Finally, I want to just the last slide, if you can, Keisha. This is a very brief overview here. There's a lot that could be dilated on. Hill-Burton, maybe it's the biggest piece of healthcare legislation that most Americans, including your neighbor, has never heard of. Hill-Burton, the Hill-Burton Act was passed in 1946, and it was a sterling example of collaboration between local, county, state, and federal government to deliver health care to the entire country. We came out of World War II. First of all, we had realized in the course of World War II how badly prepared our young men and women were, particularly our young men. The rates of individuals who did not meet the standards for the draft was incredibly high. Poverty, disease, untreated conditions, and so forth. And this struck the Congress, it struck everyone. But secondly, also in the course of fielding Army and Navy and Air Force in the course of World War II, and of course, delivering the arsenal of democracy that built the wherewithal to arm and equip that Army and Navy Air Force. We also developed a healthcare system that delivered in the field healthcare to our armed forces on the battlefield and behind the battlefield, in the trenches, so to speak, but also in infirmaries, hospitals, and so on. And so we had gained a confidence in our knowledge of how we could build up a healthcare system in the United States. And that's what we did with Hill-Burton, which was bipartisan legislation, named after the two sponsors, prime sponsors. And how did that work? The federal government set quotas, if you will, but they were quotas in terms of the numbers of hospital beds. We will deliver X number of hospital beds per 1,000 Americans in every county in the United States. That's what they said. It wasn't just bare hospital beds. They were talking about delivering simultaneously the doctors and nurses and staff otherwise that would man those facilities across the country. In brief, the Hill-Burton Act said, okay, this standard now has to be met. And so every county had to assess their situation. If it didn't have those numbers in terms of the numbers of hospital beds and doctors and nurses and so forth they needed to build that capability out. The hospitals of the time were nonprofit or public hospitals. Private hospitals were a rarity in a few urban areas or specialized fields. But if the local governments and counties couldn't afford that healthcare capabilities, the state stepped in. Under law, the state stepped in to provide the wherewithal, the resources to build that out in county after county after county, in all the respective counties. Now, if the states didn't have the wherewithal, then the federal government stepped in with the resources under the Hill-Burton Act. And so, uh, in the course of the years that followed, from 1946 forward, and that last slide is just an example of, I think it was the second hospital built in the United States under Hill-Burton. It opened the doors uh, in 1950 in Mississippi. Um, we built out hundreds of hospitals. We manned hundreds of hospitals. We opened medical schools, training hospitals to man these facilities. And so we built up what became uh, known worldwide as the best medical care system in the country, in the world. Now, doctors, most people paid for their health care out of the pocket. Families paid for they went to their primary physician. They paid for their care out of their pocket. It wasn't a big expense. Doctors were highly respected. They were well paid. They were well off. There was not some huge overhead. There was starting during World War II in particular. There were more and more companies that offered healthcare plans to their employees, but still, by and large, that was de minimis. That was not the major form in which healthcare was organized in the United States. You had a combination of local practices owned by doctors and staffed by doctors and a nurse, a secretary if needed. And some of them, of course, formed clinics where doctors each had their own offices and so forth. If they needed, if treatment was needed in a hospital, surgery was required and so forth, they utilized the local hospital, which was probably built by a church charity, Methodist, Lutheran, a Jewish charity, or other nonprofits. And then there were, under Hill-Burton, there was the building out of these county hospitals, public hospitals, to fill the gaps. And so those hospitals were utilized where the costs were at a minimum. The quality was excellent for the day. Was excellent. If we had continued with that kind of program and continued to build it up, including with the more advanced medical research and medical devices and so on and so forth, that in an economy, in a growing, healthy economy, that generated free energy for continued investments in these areas, the costs of all this could have been kept very reasonable. So it's that's not just looking back, that's looking forward and saying, well, how do we reorganize healthcare in the United States to deliver healthcare today? We can't, it's not a matter of simply, tearing up everything and just starting from scratch. We're going to have to keep the clock ticking while we repair it here in terms of healthcare. But we can do that. And what Trump has launched with this initiative, thrown out this idea, and now he's in broad discussions. He said the other day on Sunday that he's in discussions with some Democrats on this proposal as well, which is certainly reflected in the sponsorship of this latest direct primary care bill as well, Democrat as well as Republican. Then we can solve this. We'll come up with solutions, including through federal, state, and local collaboration. We're not going to create a new bureaucracy to replace the existing bureaucracy. So that's to end on an optimistic note, and we can open this up for discussion. Again, as I said, there's a lot more that could be said, but just one final note on this post 1971 process, but particularly the post 1979 process. When Paul Volcker was brought in as the head of the Federal Reserve to control inflation, interest rates. You may recall this, or you may know it from hearing about it or reading about it. Interest rates were jacked to 20%, and the entire industrial heartland of the United States shut down. That a major byproduct of that, and I've covered that in my Substack articles on this related to healthcare. We created tremendous poverty in urban areas throughout the industrial heartland, in every major city, yeah, throughout the industrial heartland. That's been documented. Well, that's who Obama and company, on behalf of Wall Street and so forth, threw a bone to with Obamacare. They said, we're bringing you into affordable care through Medicaid and otherwise through the Affordable Care Act more broadly. And you'll get health care now. You can qualify. And so, as I said, the program was broadened out by 21 million people, added 21 million people plus by 2024 into the Medicaid program. And that was political. There was a political motivation there. Not the only motivation, but it backstopped the new base of the so-called base of the Democratic Party, that of course has been betrayed itself by the Democratic Party. It threw a bone to the poor. It didn't solve their poverty, but it took away from working families, the working class, if you will, in the United States, the traditional base of the Democratic Party, that Obama and company, the Democrats of today, the woke Democrats of today, have kicked to the curb. So, to underscore that point, to just underline it, we did not increase the number of doctors in the United States. We gave a whole bunch of people, just in terms of Medicaid, 20 million plus more people, a piece of plastic with which to get medical care. But we didn't create any more doctors and qualified nurses, nurse practitioners, and so forth to treat those people, to treat Americans overall. And so, the visit to the doctor, today is a 10-minute visit, maybe 5 minutes, 10 minutes that you actually see the doctor. They run the patients through. This is something we're going to have to address, along with direct payer programs, along with increasing the funding of Medicare and Medicaid, which we can fund adequately out of a growing economy, fund them fully to fund nurses, to fund doctors' practices. We also have to increase the number of doctors by hundreds of thousands to catch up with the growing population of the United States, the legal American population of the United States. And likewise, we need roughly about 1 million more nurses. That's not just a figure I'm pulling out of the air. I mean, studies have shown that. I mean, if you're actually going to provide the quality of care that Americans had at one time, and you're going to update that for today, those are the kind of numbers that are required. So that means we're going to need probably more doctors, medical schools to train doctors. And we're going to need more residential programs, which are largely funded by CMS, that's Medicaid and Medicare. Again, Congress is going to have to increase the funding specifically through CMS for residency programs, which of course finish the training of doctors. So those are 3 elements I've named there that have to be addressed as part of an overall solution to healthcare in this country, and it can be done. So that's what I have, Keisha. Hope that's useful to folks out there, and I look forward to discussion.
Great. Yes. Thanks, Brian. That's great. I'm going to bring people in here in just a moment. I just want to bring this out a little bit more. One thing I think that is important that you're addressing outside of just a financial mechanism to address how we pay for healthcare is I thought it was really important what you brought up on this question of the energy, the free energy of the system coming from the population being able to have healthy workers. And this was really embedded in a primary concept of Lyndon LaRouche's economics. So you wish to learn about economic policies, or so you wish to learn about economics that he wrote in his textbook on economics. But it started with the question of your free energy of the system being your working population and making sure that that working population was fit to go into the workforce. And right now, we're dealing, I think what President Trump has also brought forth is something we haven't seen in a long time, or really haven't ever seen, except for the ideas that were proposed back under President John F. Kennedy. And he's doing that with the Make America Healthy again under Secretary Kennedy, Robert F. Kennedy, the the not grandson, but the nephew of President Kennedy, son of Robert Kennedy. And I think this is a very important aspect of this as well, because, I mean, as you said, we can discuss how we're going to cut healthcare costs, how we're going to build more hospitals, put more doctors in, but you also have to have a society that's committed to the health and well being of the population. And so to keep people out of the healthcare system so that you don't have a lot of people going in because they're depressed. They're on all kinds of depression medicine. They're drinking a lot. They have no sense of the future. You have young
Yeah.
people who
Very
are
true.
not qualified for
Mhm.
the health for workforce because you have all of these medicated young people, or as the Maha is dealing with the question of all of the different diseases that are affecting the population overall. I think this is a very important aspect of it in terms of preventative as well. And so this concept that you were bringing up about, how we're thinking about the value of our citizens of human life is going to be extremely important in this. And I do want to, I think this gets to a question that came up, or a statement that was made in the chat here from Gail, who also is bringing up a very important a point about doctors having lost their autonomy and not having authority. And this gets to the insurance companies again,
Mhm.
right?
Yeah. Oh, yeah. Right.
Because
Gatekeepers.
because
Gatekeepers on top of gatekeepers.
that whole
Doctors.
idea of the Hippocratic oath that doesn't even
Yeah. You
exist.
can talk to your doctor about it if you haven't already. I mean, doctors, as well as their nurses, spend half of their time, on computers, entering data and otherwise on the phone with insurance companies or
Crazy.
Medicare or Medicaid, fighting to get whatever they think their patient needs authorized. Uh, you know, uh, there's gatekeepers at every turn trying to cut corners, you know, chisel people out of the healthcare that's required. The um, the To put it positively, the physician patient relationship is fundamental. It's That's where decisions have to be made, and they uh, those decisions have to be honored and respected, as opposed to questioned up and down the line, uh, to save a few pennies and nickels.
Yeah. I mean, I know that this question this whole fight is really, it hits the heartstrings and really is something that is important to a lot of people, to
Mhm.
everybody.
Mhm.
People on this call can talk about how, including myself, how you see what you just said, where a doctor can say, I want to recommend this type of treatment for a patient, but then the insurance company comes back and say, we don't think that patient needs that. or we had a board of doctors to go and to determine different from the doctor that you're seeing. That's, that's the kind of
Right.
craziness that's yeah.
Oh yeah, no, and well,
Seen
we
it.
could go
Yeah.
on about it, but a
Right.
lot of the time, the people that are making the decision that are preempting the doctor and patient's decision, they're not doctors themselves. They're
Yep,
they're they're
exactly.
they're sitting at a computer, they're looking at a code, and determining that such and such doesn't meet, the it doesn't qualify for that coding, and is denying it. Has it never reached a board of doctors. Uh,
Right,
anyway,
exactly.
but this, it's a bureaucracy. It's a bureaucracy on top of a bureaucracy, and covering each other's ass, to put it
All
polite.
right. Well, we have some nurses and medical professionals in here who are going to give us their insights and tell us what we can.
Sure, what we said wrong.
Yeah, so I'm going to bring them in, and I just also let me go ahead and open up. I'm going to now open up for discussion for participants on the call here.